Hi, everybody. I'm here to do another episode of Carpools and Cannulas. Took me a minute to get an internet connection, weirdly. But we are here, and Dr. Greer is going to join me in 2 seconds, which is awesome. Right on time. Let's see if she's coming on. There you are.
Hello.
Hi.
How are
Happy
you?
Wednesday. I'm
I
good.
know. Happy Wednesday.
I feel like I struggle getting on live. Like I hit one button and then it doesn't do, and then I'm just like staring at myself. Is it on?
I know.
Is it
Yeah,
on?
I do that too. Or I'm like the queen of one more thing. I'm like, I can do this one. I
I
can
did
wipe
that.
down the counters. I can fold
Yes.
this laundry. And then I'm late.
Yeah.
This is why my OR day starts at 8 a.m. instead of 7:30.
Yeah, because you can get one more thing done. Always.
Yeah.
That's what
Yeah.
my husband and I differ on that, especially when it comes to traveling. So his name is Dave, and when we have a nickname for him when we travel, and we call him Airport Dave because
He likes to
he's
get there
like,
super early and hang.
yeah, doesn't want to miss anything. And I'm like, but I can go get coffee, or no, you're going to miss the flight.
I know. I should channel him. Last time we took a family trip, we literally were sprinting for the gate. We were the last people on. They overhead paged us.
Yeah, that's his claim to fame is like he's never missed a flight. So it was like, okay. Well,
That's all right.
so I can't believe it's Wednesday again. Look at all these people who are joining us.
Hello, everyone.
Hey,
We love that
Eamon.
you're here.
Yeah, thanks for joining. So we're going to talk about boobs tonight, right?
Our favorite. It's literally, we are both sending each other like the little smiley emojis with the heart eyes because we love doing breast surgery.
Yeah.
It's my favorite.
So I thought we could kick off with just a breakdown of the different kinds of implants. I'm not sure if we've even covered that for breast augmentation.
Yeah, I don't know that we have. And there were, so implants started ages ago before the FDA was created even, which is fascinating to me. There was a great book on silicone breast implants. I forget what it was called, but it went through the whole history. And silicone were the original implants. And then they came off the market briefly after requests for more data. And at that point, you could only get saline. And then silicone had been back on the market since, what, 2010? Oh, six. Okay.
Mm-hmm. Yeah. So there's like a 10-year period where you couldn't get it. And then most of those patients have saline implants that chose to have augmentation there. And I would say the other category of people with saline implants are silicone's technically FDA approved for 22 and older. So people who do a lot of 18 to 21-year-old patients, I think, tend to do saline, although you can put silicone in those patients as well.
Yes, it's just an off-label use. And the only real concern I have with that is whether the company will cover the warranty since it's an off-label use.
Correct. And I've gotten mixed feedback on that. But luckily I haven't had to make the choice for anyone, so it's been nice. But I did take care of somebody who had silicone implants put in, and then when we were thinking about doing a revision, the company did push back because they had been put in under 22. Yeah. So that was kind of a bummer. And she elected to take them out anyway. Which brings me to my, I think the primary thing about implants is that they're not lifetime devices.
Yes.
And no matter what kind you choose.
Literally every implant talk I do, I'm like, okay, let's talk about breast augmentation. These are not going to last you forever.
Right. But the same rumor mill that suggests that they'll last forever and you'll never need to deal with them again is the same concept that at 10 years, you're going to need to take them out and do something with them and exchange them.
Right. And it's not an oil change. It's more like a good roof. Yes, the average lifespan is 10 to 15 years, but if it's not leaking, you don't have to replace it.
Right. So occasionally I have people come in for different reasons, and then they'll be like, so I also have implants, and I was just wondering, I'm heading on 10 years. And I'm like, yes, you're good. Do you have a problem? No, I don't have a problem. So.
Yeah. So the interesting thing, the biggest difference between saline and silicone, of course, is if silicone has a rupture, the breast deflates. or not silicone rather, if saline has a rupture, the breast deflates. With silicone, you don't always know, especially the cohesives, and they do wear out more at 10 years. Do you do any routine screening? I know the FDA recommends every 2 years, starting 3 years out. Oh, hey, Erin, I was kind of wondering where you were.
Yeah.
But it's not like based on any actual data.
No. Yeah. So I see plenty of women who have a, maybe a silent rupture noted on mammogram, their screening mammogram. So I don't tell people that they have to. I feel like the FDA is in the process slowly of changing that recommendation for an MRI every 3 years because it's so nobody can do it. It's not covered. It's expensive. It's not a guarantee.
Well, and it's just, yeah, and how there's not a proven benefit either.
Right. And I think what the thing that bugs me the most about that is that if you do an MRI, if you just write MRI to check implants versus MRI to screen for breast cancer, they're two different things. And so just because you had an MRI to check if your implants were intact does not mean you get a clean bill of health from a breast cancer standpoint.
Right.
So
they don't evaluate it the same way.
Yeah. So it doesn't, if it did that, then I'd be like, sure, because you get an extra breast screening and like MRIs in some areas is the gold standard, but
right.
You know, whatever.
Well, the other interesting factor is that ultrasound is very effective for screening for rupture.
Right. And it used to not be. So it was we were relying on the technology to catch up. And I think now that the
high resolution,
technology is catching up. Same. That's when we had at the last Women Plastic Surgeries in-person conference in Nashville. We had a demo and a radiologist come talk to us about all that. And it was the same concept. Yeah. So you can order an ultrasound to screen for implant rupture, but also that does not count as your mammogram for the year. Like,
right, because
that's not a screening study.
Ultrasounds are targeted. Yeah, the mammogram is looking at the entire breast. Ultrasound is only if they see something specific to look at or if you have a palpable mass. It's a targeted study. So, but it's the other interesting thing is ultrasound is now becoming widely available in offices. I actually just got my ultrasound last week.
Oh,
so this was a very timely talk. Yeah, I got the Butterfly, which is a high resolution ultrasound. It plugs into my iPhone, which was amazing. And I got it with the intent of just checking in on all of my breast aug patients so that we can follow them long term without having to send them to radiology for formal studies.
That's awesome.
Yeah.
We know how it goes. I've not pulled the trigger on that. Does it come with a course so that you can check implants?
It has a lot of modules on it. I have looked at a lot of the ultrasounds that have been shared through like the talks with ASPS and I think it was Pat McGuire was sharing some. But the overall recommendation I heard was just like when we were learning to read CTs and chest x-rays, is just look at a ton of them. So right now I've been ultrasounding everybody who has everybody with implants. If you come near my office, then you will get ultrasounded. By the way, I looked at my own kidneys. This thing is really, it's really good. You can do like fast scans. You can do echocardiograms. The resolution's very good. So I've just been looking at everybody's implants with the caveat of I'm not a radiologist. I'm just learning. I did have a patient whose implants were 10 years. And I said, I'm happy to look at them for you. But if there's any concern, we're going to just order an ultrasound and have a radiology read, which we ended up doing because I couldn't tell her for sure that they were not ruptured. You know, the implants that are like 3 and 4 years out, I'm just looking to see what they look like at this point.
Right. Yeah.
Yeah.
And then maybe you'll find somebody who comes in with a known rupture and you can check it too.
Exactly.
Right?
Exactly. And that's, you know, after the learning curve, I think it's going to be very, very helpful. The other nice thing is I saw a patient today who had implants removed and was worried that maybe she had thickened capsule. And, you know, it's very easy to see the homogeneous density of breast tissue and no seroma. So that was nice. I thought it was going to take a lot longer to ultrasound people. And like, you just whip it out, plug it into your phone. I see your puppy. He has a sweater.
I know because I live in Southern California and it's gloomy. So
the
kids
cold.
put the sweater on her. It's, you know,
that's adorable.
70 degrees. So they were worried about
it's reasonable. Yeah. But I have to say, like, I didn't pull the trigger on it for the longest time because I thought it was going to add all this extra time in office. I think I ultrasounded 4 people today just because I could. And
it wasn't.
Yeah, it like took 2 minutes and it was nice to be able to look and get views. And some were like, I think I had a 6-month implant patient. It was just like, let's see what these look like so that we know. And then next time we'll check them. I think it'll be really useful for people.
That's great.
Yeah.
I'll have to look into it. I'll have to search. It's on my like laundry list of things to.
Yeah, I mean, compared to the old technology of a $45,000 cart on wheels, now it's like a $2,000 probe. Hi, Ella. Do you want to say hi? Oh, here, lean over. There you go. Okay.
Can I have a piece of gum?
Yeah, go ahead and have a piece of gum. Okay. She's good. We extended the kids' bedtime to 9:30, so you'll probably be seeing them a lot more.
It's summertime, huh?
Yeah, well, and honestly, they're just at 5 and 7. 8:30 is not really a time when they fall asleep anymore.
Yeah, we're in summertime mode too, so everyone stays up late. Sometimes later than me.
I know, right? I'm like falling asleep at 9 o'clock, and
they're like, "Oh, can we stay up later?" No.
Yep. But then the next morning they have
go to your room.
Yep, exactly. Okay, so different types of implants. We kind of glossed over saline versus silicone.
Mm-hmm.
There's people always ask about gummy bear implants, and really, I think most of the silicone implants on the market now are a cohesive gel because
they all are.
Yeah,
mm-hmm.
That has become the new standard of care. Just meaning, if you cut it in half, it's going to hold its shape at least while it's new. 10 years down the road, that silicone may change a little bit.
Right.
But the other big type, people ask about the anatomic. Those are a little hard to get now.
Mm-hmm.
Because the other big implant division was smooth versus textured, which has to do with the shell. And if it has a really fine, pebbly texture, the idea there was to keep it from displacing. And for the anatomic, which are a teardrop implant, you need it so that they don't rotate. But the risk with those is a very minute increased risk of anaplastic large cell lymphoma.
Correct. So there's 3 major implant companies that do silicone implants, and one of them had pulled off their shaped implants off the market. Mm-hmm. That's Allergan. The other 2 are still available. I was surprised somebody asked me about anatomics the other day, and I was like, oh, I don't do those because there's 2 left, and it's not worth the risk of having textured implants and having a problem down the road.
Yeah, and I think with
smooth.
Yeah, and the smooth, when you hold them up, the gel settles into a teardrop shape. Like,
right.
They look fantastic. They feel very natural.
Which is the other major difference between silicone and saline is feel.
Yes.
Oftentimes you can't tell what somebody has just by looking at them, but you definitely feel the difference if you have very little breast tissue overlying, you can tell the difference between a saline implant. Yeah.
Yes.
Then, do you have much experience with ideal implant? So there's another type of implant.
That's right. Yeah, let me think. It's a silicone center with like a saline surround that you can adjust. So it's supposed to be or is it backwards? I forget.
It's totally saline.
Oh, but it's supposed to feel like silicone.
Yeah, it's a double saline.
I've never actually used it, and I've heard
mixed reviews.
Yes.
Yeah. I haven't used it either, although I have offered it. I just haven't found the right person for it. I just feel like if you're really concerned about the feel, then you're just going to go with silicone.
Mm-hmm. Exactly.
Mm-hmm. There used to be, I think it was the Becker adjustable implant.
That's what I was thinking, like double lumen. I've taken one of those out. I've taken them out. Yeah, I didn't use them, though. My predecessor used them. But I think, with silicone, the only reason I ever have people ask for saline is if they want to know that it ruptured. And I think with the growing availability of in-office high-resolution ultrasound, patients are going to be much more reassured that, hey, I can go in once a year and get it checked. No big deal.
Yeah. I did actually, there used to be an adjustable saline implant. I'm not sure if it was the Becker or not, but it had a little remote port. And so you would put the implant in, and then you could fill it more or take some volume out, just like an expander afterwards. And the patient I had them done in Hawaii like a couple of years earlier, but never went back to get the port out. So she still had the port in place. It was
so
very
funny.
Random. But yeah, they don't make those either. I like the concept though. Like, we're going to put these in, and if you want to be a little bit bigger, we can just in office add more. Like, not a terrible concept, but.
No, I mean, it's really not. But, and that's another common question is like implant size. And there's this, I don't know if it's like a myth or like just advice passed down that you should always go a little bit bigger because you're going to be sorry if you don't. And I'm told that by so many patients. Do you hear that a lot too?
Yeah. Well, what I do see a lot is women who are farther along and are ready to exchange their implants are like, listen, we had a conversation. I said I wanted 250 cc implants or just wanted a lift. And then I woke up and I had these 400 cc implants
Yes.
in. And I was
I
told,
hear that so often.
I know. And I was told by the surgeon that they just looked better and it fit my body better or whatever. And I'm
Yeah.
like, okay, well, no, we need to come to an agreement on what size implants we're going to put in before surgery. I'm not going to do, I just thought another 50 or 200 cc's was,
Right, Jack. Only true about diamonds. Yes.
yes. If you're
bigger is fine there. Yeah, with implants, like,
that.
why would a woman not know her own body and know what size she wants? That drives me bonkers.
It happens all the time.
Yeah, I did actually survey a bunch of my AUG patients just out of curiosity to see if they were like perfectly happy or if they initially thought it was too big or too small. And it turned out like 70% of women ultimately loved the size they chose. Like maybe initially they thought it was too big or too small. And then when things settled, they were really happy. And then like 20% wish they'd gone bigger. And like 10% wish they'd gone a little smaller. So by and large, the majority of women pick a size that they are happy with.
Yeah. And as I tell, sometimes we decide on, right, the type of implant, which we talked about, saline versus silicone, the incision, which we can talk about, the pocket location, which we can talk about, and then the size. Everybody focuses on the size. And sometimes I have people like, pulling their hair out because they can't decide between a 345 and a
365.
360. Yeah. And I'm like, it's a shot glass. So don't beat yourself up over it.
Right.
It's literally this much volume.
If I have a patient sitting up and I have 30 cc's more on one side, I have to really use my discerning surgeon eye to tell which side that is. So once they get in there at like 60 to 100 cc range, I'm like, you're gold. You're going to be happy with anything you choose here.
Right. Yeah. And I even had somebody who wanted to exchange and she couldn't decide between, I feel like 425 and 50. And her husband was like, no matter what you choose, you're going to overthink it and then be sad. And so it
sounds like he knows
so it wasn't even that hard.
Yeah.
So what they came to me with is, we want you to put in one of those two sizes, which like I said, doesn't matter. And then, put the implant card in an envelope. It's like knowing the sex of your baby. And then that way, when I feel like I want to check that or give it to her husband, and then when she wants to know, she can check it later.
Did you do it?
Yeah, I did that. I was
How
like,
did you decide which one to use?
Know.
That's so funny.
It was a little bit based on like what she had in there too. So like sometimes people are like, I want to be a skosh bigger. Oh, okay. Well, what do you have? I don't know.
No idea. So then you're kind of guessing.
It'll be a mystery until I pull one out and say,
and
it's a 400. Okay.
Order a bunch. You're like, okay, move up a little bit.
Yeah.
Yeah.
So people are like, so I do tell, there is a lot of anxiety about the size, and then it ends up just being, it's like,
they're happy with it.
I know.
Most of the time.
I wonder if they ever opened it. I don't know. We saw her like at 6 months, and then I just didn't want to bring it up because it was such a hot topic. It's like, you don't want to be the one who's like, oh, you're having a girl. Oh, you didn't want to know. Sorry about that.
That's funny.
Yeah. So let's talk about incision location. We have a few minutes left.
Absolutely. I do inframammary. Always inframammary. Exception being if somebody has tuberous breast, which is where the lower pole is constricted and the crease is higher, and usually the medial aspect of the breast is a little narrowed, then I will do an incision around the areola so I can release the breast tissue and allow that to stretch. But other than that, I always do inframammary because it's a great scar. It hides so well.
Yeah, I agree. I don't like going peri-areolar unless the patient already has that incision and I'm doing an exchange. Gosh.
It's a word. It's a word. I thought I had a
legitimate word. I feel like it's a medical term.
Yeah.
So I think, that hides the best unless they already have that incision. And even then I try to stay out of it because, if you go back and see people who have had implant removal, it can indent. Yeah. And it doesn't have anything to do with it. It just does that. And, so I do prefer inframammary crease. I'll use vertical access if I'm doing a lift at the same time, which is a whole other conversation. I'm not going to make a whole brand new incision if we're using, a lollipop lift. And then pocket location, I we're going to have a panel on this at the upcoming women's plastic surgery retreat in February.
Nice.
We're going to like do some dueling, you know, submuscular and then subglandular, but I do mostly submuscular. Like
Ditto.
99%.
Ditto.
Yeah.
And then there is the subfascial, which is under the pec fascia. And there are some diehard subfascial fans too. Oh, and just so we cover the other incision types, there's periareolar, but there's also a lot of proponents of the axillary incision where it's like up hidden in your axilla. Mm-hmm. I know a couple people who do that, and it's kind of a niche thing because there's no scar in your breast. I personally don't get it because at some point you're going to have a scar in your breast when that implant comes out. They do not take it out through your armpit. And if you're wearing a tank top, the incision is totally visible.
Yeah, I don't love that incision. I actually have taken a pair out through the axilla.
How was that?
Nobody else offered to do it. It was not as hard as I thought it would be.
Well, that's good.
Yeah, I think if you're not if you're not doing it endoscopically, so when I trained, I worked with a guy who did a ton of saline implants, transaxillary, and it was a blind, what we call blind technique. So they would make the incision
and then just put a dissector down and
and like make the pocket. And I was like, but
I've seen it. I know some people who do it endoscopically, so they have a camera, they're looking, but I think the reason I hate it is I remember once having drinks with somebody in a bar and I saw her incisions, and like the fact that I can tell that you had a breast dog when you're fully clothed in a bar, to me just seems like not what I would go for.
Right. Oh, the tuba. Mentioned only to be dismissed as a option.
I had a friend who had a tuba.
Did you really?
Yeah, so it's transumbilical breast augmentation, by the way, guys. I actually saw it on like the Learning Channel in college, and I was like, really? So you go through the belly button, but you can only use saline implants because you can't shove a silicone implant up there. It's a long dissection, so you're going blind, and they can only go above the muscle. There's a lot of downsides to it.
There's so many downsides. Tuba, so transumbilical breast augmentation, go through the belly button. The one time I've seen it done was actually watching Dr. 90210 back in the day, before I was a plastic surgeon. But I think I might have been, I don't know, I knew enough to know he did a tummy tuck. So it raised the abdominal flap and then went through the abdominal flap to do it. And I was like, again, that isn't actually a tuba. You're now just going through the abdomen. That's so bananas. It wasn't even, I was like, you can't even get that right.
That would be like terrible. A TABA, transabdominal breast augmentation.
Which also is not a great plan. Yeah.
It's just, you don't get very precise. No, you can't see anything. Yeah, it's funny. Like the people who seem to worry about scars on the breasts are by and large men. I mean, women worry about the lift scars because they're on the front, but that inframammary crease scar, like you are not going to see it unless you have a mirror, and no one else is going to see it unless you are standing above them naked. And if that is your job, or your job involves that, or that happens regularly, I mean, you know, I don't think that's a huge surprise that you had an augmentation.
Right. That's your line of work.
Yeah.
It's not gonna, and I feel like the incision just heals well. And
it hides beautifully. Like I've seen women 10 years out where you are struggling to find that scar.
Yes, 100%. Where you're like, where did you have this done? I gotta find the incision.
Exactly. You're like, wait, I want to go through the old scar, but I gotta find it.
Right.
Yeah. It's just like no need to overcomplicate things.
So like I said, I do most of mine submuscular because I think it holds the implant up well over time.
Ditto.
And I have not played around with subfascial. I've looked.
Yeah.
I check when I'm there to see like what's the fascia look like. Can I do this? And I'm sometimes underwhelmed.
Yeah, it's not a thick layer. It's really not.
So I feel like it's mostly subglandular still.
Yeah, I've heard, I mean, it's something that I would definitely recommend if you're doing top surgery for male to female, because the pec muscle is so strong, you can really get a visible animation of the implant. On most women, like you flex your pecs and it's like, doop.
Right.
But
and I feel like men have a thicker pec fascia.
Yeah.
Because when you're doing gynecomastia, you can definitely see it. When you do that surgery, you're like, oh, that's there.
So with that, the implant can settle a little bit better. But there's also the total submuscular, also known as the Holly Dawn technique, because she has popularized it. And that's not one I've tried yet either. I've definitely released less of the pec so your pec muscle inserts on your sternum in the midline and then on your ribs just for a couple of centimeters. And normally we'll release it all the way to the sternum so that the implant can settle. But sometimes I'll leave some of those medial fibers intact, especially if it's a larger implant that needs support, but only if I'm doing a lift or they really have no ptosis at all. Because you don't want the breast dropping off the implant. That's not a good look.
Right. Yeah, so I have tried adding that in a little bit as well, but it's in the right patient. And what I like about, though, trying to stick with that concept is that there's almost no lateral dissection, which I think the less you expand that lateral pocket, the better off the patient is over time, because everyone hates when your implants start moving
to the side.
Chest. Yeah, and I tell people, like, your chest is not a table. You know, it's concave, and so everyone's breasts will if you see somebody with naturally large breasts, when they lay down, they move to the side. They
fall to the side. Well, and that brings up the topic of implant profile, which we haven't talked about. And I find patients are either hyper aware and they're like, I want this profile, or they have no idea what it is. So implant profile is basically how big the base diameter is for a given volume of implant. So higher profile implants project more off the chest. And this actually isn't something patients need to choose. We choose it during the exam. We measure the width of your breast. And then when you pick the volume, we match up the volume with the base diameter that fits your breast. But the thing is, once you get into the like 600 and 700 and 800 milliliter implants, we do need it. There's a lot about breasts. We could talk about breasts forever.
There's so many different kinds of implants. So, oh my God.
but that's the thing. Like, if you want a really big implant, you are going to have side boob, and it is going to stick out. And that's something that's really important to understand. Because I have a patient who doesn't love the side boob, but she loves the size. And I was like, we can close off the pocket there, but we're going to have to go down like 150 cc's in size because the chest is narrow on some people.
Right. Yeah. So I think so I do adjust if they want a certain volume. I'll adjust the profile to get that volume in there.
Can I help you, love?
I want to snuggle with you.
Okay, why? We'll come snuggle in a bit. We're almost done, okay?
You have 1 minute.
Yes, please 1 minute. We're almost done, and I'll come snuggle. Okay, don't burp. Gross.
You're not selling the snuggling if you burp. Of course, my kid is chit-chatting with my nephew.
I saw. I was like, oh, Bella, there we go. That's fine.
So they're just reaching out to me remotely from downstairs. That's awesome.
That's awesome. Wait till they start messaging like, Mom, I want gum. I want snuggles.
Can you come downstairs for a second? So good session. I feel like there's more to talk about breast augmentation.
Always.
Break it down in another session.
Yeah, we could talk about it next time maybe and talk about like recovery, because that's a really good topic. And there's lots of fun little tricks to help people. Oh, thank you.
Thanks, Sally.
For saying we're amazing. But yeah, that's one of those things where people are really afraid of the recovery. And then most of my patients are like, oh, that was not awful.
Yeah. Yes, we can definitely talk about that. So maybe we'll talk about the actual surgery, like what to expect that day, and then recovery. So
fabulous.
Next session. I feel like these 2 weeks come up faster than I expected. I had to look at the calendar again.
I know. I was glad you did. I, for some reason, didn't even put it in my calendar, but I was like, I think it's this week.
So, all right. Yeah, I know. It's Erica posing as Ryan, but I swear he was on there for a second saying hi to Bella. Or maybe not. You might be right. The diamond comment. Yes. All right. All right. Well, Go snuggle, Jen. And
I will.
Go make sure dinner didn't get burned.
Yeah, fabulous. I'll see you in 2 weeks.
Okay. All right. Bye, everybody. Bye. Thanks for joining.